Hey, everybody. Welcome to this month's LinkedIn Live event. Super excited to have you here for this month's event. As always, we do appreciate everybody tuning in. We've had some really good traction over the past few months, and this month is hopefully no exception. This month's LinkedIn Live, I've got two of Advize's behavioral health experts. We're going to be talking a lot about behavioral health. We're going to talk about coding, documentation, the who, what, where, why, when, hows. We're going to talk about some of the codes that give us a little bit of heartburn, and we're going to talk about, from an investigative and an auditing perspective, some of the things that we should be thinking about from that SIU perspective, but also if you're on the provider side, some of the things that you should be thinking about from the provider side, from a compliance perspective and auditing and coding perspective as well. So I've got two of my behavioral health experts here at Advize. I've got Renee Sloan and I've got David Bolden. And if you've tuned in to some of our previous LinkedIn lives, you recognize David. He's one of our lead auditors here, has a great background in behavioral health, and Renee Sloan, who is a member of our SIU investigative team. Renee, I want to start with you. Tell us a little bit about your background so people know that you're not just a fly-by-night person. You actually do understand behavioral health, and you do understand the way these investigations work.
Yeah, just a little. I actually have been in the healthcare field now for a little more than 20 years. I actually have been a certified professional coder. As of February, it will be exactly 20 years that I've been a certified professional coder. And through AAPC, I also have my certified coding specialist certification through HEMA as well. And for the last about 4 years, I've actually strictly been working within the behavioral health, fraud, waste, and abuse arena, and in total have spent the last 10 years in fraud, waste, and abuse as a whole.
And yeah, and so you do bring to Advize, and we're super excited about that, obviously, is you bring that unique ability of having the investigative part of it, the coding part of it, and from, if you think about it just from an investigative perspective, from an ROI within an SIU, you really do have the ability to kind of do a lot of that work that sometimes requires having multiple people be involved. You're kind of a one-stop shop, and that's what we really appreciate, is a lot of the people on our teams have that ability to kind of do that. So, and David Bolden, welcome back as always. My go-to guy for things in the auditing and the compliance space, not only a certified professional coder, but also a certified healthcare compliance officer. And so remind for people who don't know who David Bolden is, but then the people who do know who David Bolden is, remind us. Let's talk a little bit about that background that you've got.
Awesome. Thank you, Eric. Well, I work at Advize as a coding documentation auditor. I started off way back in the day as a direct care worker, actually, in behavioral health, where I was working with kids and adults in the respite space, day programs, inpatient hospitals, mental hospitals, things like that, and kind of moved into that compliance realm, like you were saying, where I was a compliance officer for a small agency in Tucson, Arizona. Shout out to Arizona. Yeah, I've moved on up. I've been doing healthcare for over 15 years. Behavioral health is kind of my go-to. It's the specialty. And then also as an auditor, I look at medical records and make sure the documentation supports the codes that are built. And just like Renee, I'm also a CPC, like you're saying, and then a compliance officer. So. Yeah.
Yeah, and for those who want to know a little bit more about David, we did have the great pleasure of highlighting some of David's personal and professional life in one of our newsletters. We do that with some of our employees, and so you can read about David's background. David is also a U.S. Army veteran, and so we always like to thank him for his service because he spent a number of years dedicated to protecting the freedoms that we all have here in this country. So it is important to always recognize our service professionals in this country. So with that being said, let's dive right into this. The behavioral health area and the fraud, waste, abuse, compliance related issues on the provider side, and then obviously from the SIU side, it's the topic du jour. Right. And it's now become something that's at the forefront. There's a lot of money that comes in for a variety of things. And so, Renee, I want to start with you because it all starts with being properly licensed and properly credentialed to be able to render these services. So before we even get to the fraud, waste, abuse, compliance issues that come about, it starts with the provider being properly licensed and credentialed. So let's talk a little bit about that, Renee.
So as some people may know, your states are actually the ones who actually provide licensure for all of the professions, such as your licensed professional counselor, licensed clinical social worker, licensed specialist of clinical social work, and also for skilled labor as well. So this, as I said, includes behavioral health care. The states also regulate the requirements for the licensing of these professions, such as the levels of education, the practicum or field experience, as far as the hourly requirements, and also successful completion of any board certified examinations. So in addition to like your LPC, LCSW, LSCSW, since 2009, the applied behavioral analysis profession has rapidly become more regulated as well. And with that, the ABA therapy, there are additional certifications through the Behavioral Analyst Certification Board. So, you have your board certified behavioral analyst, board certified behavioral analyst with a doctorate, and then, of course, your board certified assistant behavioral analyst and your registered behavioral therapist. So, some states actually do have licensure for actual behavioral analysis, so an LBA. But along with these licensing requirements, there are still other regulatory bodies and your payers that require specific levels of licensure or certification to be able to practice. And it's always a good rule of thumb to be educated on any and all requirements as set out by whether it's your state administrative code, any statutes or laws, your payer provider manuals and contracts, or any other directives or newsletters that may have been sent out by like the Department of Medicine and Health within a specified state. But also along with those certifications and licensure, there's also the credentialing that is required by many payers. So, providers really need to make sure that they're following all of the requirements through all of their regulatory bodies and paying attention to what is required and making sure they're doing their research.
Right. And from an investigative perspective, so there's a lot that you provided there, which give you a ton of investigative pieces of the puzzle, right? So, all of these boards and the state licensure and all that all have websites, right? A lot of that is public facing information. And with just a couple of mouse clicks, you can get onto a state website and identify, is this person licensed? Are they credentialed? What are those credentials? What are the requirements? Anecdotally, I was talking to you before we came on live about a case that I worked on. I was at the OIG in New York involving an individual who had a PhD in school psychology. And in New York, school psychologists cannot perform clinical psychology services. And the only way that you would know that is you'd have to look at the New York State regulations and the requirements under that licensure. And in that case that I was working on in particular, the provider had set up his own practice, was rendering talk therapy. He was rendering services that were Medicare, Medicaid, and commercially insured reimbursable, but he was billing them out under the NPI number of one of his staff who is a clinical social worker or a licensed clinical social worker or a PhD level clinician. So while he was actually rendering those services, he was misrepresenting those services. And so, the take home for me on that is the importance of being able to go through and from the investigative perspective is to do that. And the one thing that you brought up, which we talk a lot about to our SIU clients when we do our training, is the importance of pulling network contracts and plan contracts to understand what are the parameters for being able to bill and render those services. What codes are you allowed to bill? What codes you're not allowed to bill? So that's definitely a piece of the puzzle. So David, I want to now go to you because a lot of that from what Renee just said, then leads to, from a compliance perspective, a fraud, waste, abuse, and an auditing perspective, is the documentation that has to be part of that in order to bill for some of the codes. You've got to have that appropriate documentation. So talk a little bit. We're going to get to the codes specifically in a minute, but I want to talk about the the generalities of documentation, the who, what, where, when, why of documentation, and the importance of documentation.
Yes, the 5 Ws. Gotta love the 5 Ws. So yes, that is, I think, by far one of the things that we see in the behavioral health world, as auditors, as coders, as anybody who's reviewing the records. That is the piece that is usually missing with regard to these services, is the documentation does not support whatever service that they're saying that is being rendered, right? So and just from that, those 5 Ws, so they're not explaining the why, they're not explaining the how. The who, the what, and when are usually within the EHR, right? So EHR is now the magic of technology. It pops up, and it usually is already pre-populated within a record. But the why and the how, those are the crucial pieces of behavioral health services. So why is that person getting that service? How are they receiving those services? So what therapeutic interventions are you using? What clinical interventions are you actually providing to them to make sure that they're meeting those treatment goals that are identified within the medical record? And that is a crucial piece of it, as well as those treatment goals. Like, that is the driver of these services. So providers need to have very clear a clear understanding as far as how those need to be documented within the medical record as well. So for instance, let's say you're coming in for depression. Like, psychotherapy services and any type of behavioral health service, and most of them, they're revolving, right? Like, you can have them and you start and stop, but they're not, all of them aren't meant to be a lifelong kind of service, especially for like psychotherapy services. You're supposed to be going in, you're getting those services, you're making sure that you're able to cope and use those natural skills that you have, those natural supports that are within your life, in order to make sure that you don't necessarily have to have a clinical person, you know, providing those services all the time. And that's not something that you normally see within documentation from a lot of the providers. And I'm not saying all, I'm saying a lot of providers, they kind of don't understand that piece of it, where, it has to be documented. And, from an audit standpoint, if it's not the documentation, it's not there, right? So it really comes down to the providers understanding what to document. So as an auditor, as a reviewer, they're not making their own assumptions within the documentation, because that's what's happening if you leave those things out.
And a little bit of a divergence in the BH world from in your traditional medicine, where you've got a lot of times a SOAP note, right? Subjective, objective, assessment, and plan. Psychotherapy notes are a little bit different, because you really need to have the who, what, where, when, why, and how to be able to meet some of the criteria that's required. So let's stay with that, because now we get into that documentation. And, I think part of the situation is that when providers do things, they tend to document the services, but they tend to be very poor at translating those documented services into the overlay of the appropriate code. Right. And I have this conversation with the providers all the time, where they say, well, I documented the things that I do. And I go, okay, but you're not necessarily coding to that. And so the piece of that puzzle then becomes ensuring that you are coding properly to what you document. So let's talk about a few of the codes, and then I'm going to go to Renee, because there are a couple of codes that kind of stick in her craw. But I want to get first from you, David, a little bit about what are some of the common codes that you see in the BH space, and what are the general, we don't need to get super granular because we only have a little bit of time. But sort of from the 15,000 foot view, what are the common codes that you see in the behavioral health ABA world, and what are some of those requirements that need to be met in order for someone to say, hey, in order for me to get paid for this, it's got to be documented this way?
Yeah. And so definitely, hands down, I would say a lot of my experience has been around psychotherapy codes. So that 60-minute, either 30-minute, 45-minute, or 60-minute psychotherapy code, which is your 90832, your 90834, or your 90837, respectively. And so because those codes have a time component to them, the documentation it's crucial that the documentation has that time component within it to make sure that you're billing the appropriate code for whatever time you're spending with that particular member. And so a lot of what we see in this world is, you're providing psychotherapy services, but there isn't a clear amount of time that's being spent with the member. Or on the opposite end of that, every encounter is 60 minutes, right? And so that in itself, is something that is cause for concern, because if every single time they come in there and it's an exact 60 minutes that they're coming in, realistically, that's something that needs to be looked at from a SIU kind of fraud, waste, and abuse standpoint, because people they come in late, even when documentation states that the person's coming in late to the meeting or to their session, but you still bid 60 minutes. You see what I'm saying? That those two things don't correlate with each other. So I would say the time component is a huge thing with regards to psychotherapy codes. In the home and community-based services, the HCBS world, another one is providing home health services. So home health services is a time code, and majority of the plans that will be reimbursing for those particular services, you have to clearly define in the documentation how much time was spent providing services within that home health space. And so, them sleeping and taking naps during the middle of the day, that's not a service that you're providing, because what are you doing directly with that member when their eyes are shut in their room sleeping? You see what I'm saying? Right. So there's really no way to say that you spent 24 hours with a member without truly saying, what did you do for that 24 hours?
Right. I mean, look, I'd love to get paid for sleeping, napping,
Right.
eating, all of that stuff. So yeah, so when I always talk about it, the shrink's hour, right? A shrink's hour is 50 minutes because a lot of the sessions are 50 minutes. And yeah, for people who are coding geeks, you're talking about services that are in the 908 category of things, and that's where you have to look at those time services. So Renee, you've got a couple of codes that give you concern, and when you see use of these particular codes and you see providers billing for those codes, it makes you concerned. And I know we talked about this. The two codes that kind of that raise the hair on the back of your neck are 97153, 97155. So if you can just explain, what are those two codes, why do they give you a headache, and why does it make the hair on the back of your neck stand up?
So, if there are any behavioral health providers who are not familiar with the 97153 and 97155 are actually both adaptive behavioral analysis therapy codes. The 97153 is actually adaptive behavioral treatment by protocol, which is usually administered by a technician under the direction of a physician or other qualified healthcare professional. It does specify that there must be face-to-face time with one patient, and it is also a timed code, as David was discussing, and it actually comes in increments of 15 minutes. With the CPT code 97155, it is defined as adaptive behavioral treatment with protocol modification, administered by the physician or other qualified healthcare professional, which may include simultaneous direction of a technician face-to-face with one patient. And this, again, is also a timed code of 15 minutes. So a lot of times we do have some queries from providers regarding these two codes, because the language and the definition is what really stands out to us as SIU auditors. Your 97153 is, again, just to reiterate, the treatment by protocol, and it is administered by the technician under the direction of a physician or other qualified healthcare professional. Whereas the 97155 is the treatment with a protocol modification. So there must be that aspect of there's some sort of modification or change to the protocol, and that should be administered by the physician or the or other qualified healthcare professional. And this is one of those things that, as I've been studying law, that the part in this next part of the definition, it says which may include simultaneous direction of a technician. So this is a sticky part that a lot of the BCBAs and other providers, they get into a sticky wicket about, because they may be providing supervision. So it's not a hard line, and it's some gray area that some of the societies and other ABA providers have a little bit of a fixation on. But there is that differentiation between the 5.3 versus the 5.5, that there needs to be the protocol modification. So we need to see that difference in the protocol, what you're actually performing with the patient during that service, and whether you as the BCBA are performing the service, or you may be supervising the technician, but you as the BCBA still need to be providing that supervision and that observation of what needs to be changed in the protocol. And that needs to be clearly documented within your progress note.
And so do you see instances where the documentation is gray, where you've got that may not, like one of those, but but for the fact that the policy or the definition is as clear as mud, has created that, right, that fine line of where do we draw the line of fraud, waste, abuse, or hey, the policy is just not clear enough, so we can't make that differentiator, right? Because oftentimes we know on the provider side there may be instances where the providers are trying to game the system, and the gaming of the system might be on the waste abuse side, not the fraud side, because the fraudsters don't care about what the policy says. The waste abuse people may be looking at the policy and saying, well, this isn't clear, right? And the policy needs to be clearer, or the definition of the code needs to be clearer. And so you get into this back and forth about how you might interpret it. And we see this, right? We see this with people who are auditors and coders. You and David may look at the same document and not have a consensus about the proper code or the impropriety of the code because of a way that you interpret a particular word or a line. But so from an investigative perspective, how would you address an instance in which the documentation is in that gray area? How do you make that determination about, hey, this is good, this is not good, or I can't make a decision? So if you can't make a decision, it has to be good, right? Because you have to give the provider the deference.
Right. I mean, generally they have said, as far as management will err on the side of the provider. But, if you do see in the documentation that gray area, and generally it is that situation that you're running into where there's not a very clear discernment of, what was the original protocol, and then how did you change it? And so that's where we're finding, or a lot of times we want to give more direction and education to the providers that you need to elaborate or provide that clear documentation, kind of as David was saying earlier. Provide that clear baseline of what was the protocol, and then you state blah 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 XXX. The change to that original was, with your follow-up statement. So it's an if then, or a how did we change it, back again to David's point of how and who did the work, who made the changes, how was it changed, etc.
So while we're on that topic, it then gets into this whole discussion of direct care versus indirect care, right? Because that all kind of flows together. And one of the issues of people who aren't involved in direct care, you don't get to bill for these QA reviews, the ancillary type stuff in these instances. And so let's talk a little bit about some of the things that you've seen and some of the ways that providers are trying to kind of ride that fine line or skirt the rule.
In terms of those two services.
Yeah, and right, and then just generally kind of that issue of, these individuals that get into like this QA where they're essentially amending or making changes to the original medical record.
Oh yeah, we have seen instances where they have like a quality assurance worker where, someone who was not there during the face to face with the patient, because that is the biggest part to all of your services, is that you have that face to face. Whoever performed the rendering service needs to be the one who is documenting. And so we do have these instances where we've seen a quality assurance worker or some other provider who is not the billing provider, who is not the rendering provider. And we've also seen where they are also not they are not credentialed with that payer, that are performing amendments or changes or adding additional information to the documentation, and that's not how that should work. What should be occurring is the rendering provider who provided the service should be actually making any changes, updates, and of course following the policies as set out by either CMS, your other payers, or any other documentation guidelines in regards to either striking out and making that amendment and having the appropriate documentation showing that who made the change, what day, time, etc., and their credentials and certifications and licensure.
Right. So all those things we just talked about, early on. So David, we're coming a little bit close on time. So I want to just get back to you because one of the things, and you brought this up, but one of the things I want to kind of give you the final word from the auditing perspective on is this whole premise of timed codes and the impossible day that comes about from that. And we know that as the E&M world has morphed, right? You have the 95, 97 guidelines, now the 2021 guidelines. You did an entire LinkedIn Live webinar for us back in January, I believe, on the 2024 E&M guidelines. There have been a lot of podcasts, a lot of LinkedIn Lives, a lot of webinars on that. So we're not going to spend a lot of time, but obviously the big differentiator is that in the E&M world, time is not the main factor anymore. It's the medical decision making of the provider. But in the psychotherapy world, in the behavioral health timed code world, it is the factor and it is the driving force on that. So from an auditing perspective, what are some of the things that give you that pause to say, hey, and I'll tell you, we've done some projects here with providers where providers will say the the client or the patient, the member, whatever you're calling them, we did talk therapy for 50 minutes. They were in the chair. We had a session. It was 50 minutes. And I'll go back and say, I am not disagreeing with that. I looked at your calendars. You're scheduling these people at 60-minute increments. So you're giving them 50 minutes. Then you give yourself a 10-minute catch-up break, reset break, and then the next patient comes in. I'm not arguing, but your documentation is only showing 30 minutes or 40 minutes. What are some of the things that you're looking for to really substantiate that time-based code, very different now from the E&Ms back of, prior to 2021? What are some of the things that you're really looking for to demonstrate that this person, that the service rendered is meeting the time mark, whatever it is, 20, 30, 40, 50 minutes?
And so that's interesting because it's a hot topic always, right? Time is always the hot topic, especially in behavioral health. So, and it's a little more clear with regards to the 15-minute codes, like Renee, you were talking about, where it's each 15 minutes as a unit, right? So you use the TMS 8-minute rule, then you go off of that, right? And you bill your time that way. But for the psychotherapy codes, when you have that kind of time range. So for instance, the 90832, which is your 30-minute, you can bill anywhere between 16 minutes and 37 minutes, right? And so anything less than 15 minutes or 16 minutes is not billable as psychotherapy, right? So when you get into that kind of world of time ranges, like you see in psychotherapy, it's really important, or it's suggested at least, to have those start and stop times in the documentation. I know it's not a requirement, and to be honest with you, there is a requirement for that time component. But as far as the start and stop, a lot of the providers will fight that and say, well, no, I don't need to put a start and stop time in there. Why do I need? I just said that it's 45 minutes, or I said that it's 50 minutes, or I said it's 60 minutes. And while that's acceptable, you, again, like you were saying before, Eric, it kind of, you're having to kind of do that investigative work and look at it and say, okay, let me see your calendar. Let me make sure you weren't doing anything else within that time frame in order to kind of minimize that time that you're saying you were spending in psychotherapy. And I see that a lot, especially like you're saying with regards to the E&M and psychotherapy in the same visit, right? You have the physician or the practitioner saying, I spent 60 minutes providing a psychotherapy service, but I also spent an hour with the patient. So it's also a 99215. You're like, wait a second, how are you spending an hour in E&M, but then also an hour in psychotherapy? That's 2 hours. You can't say those two things don't connect with each other. And whatever time that you're spending providing the E&M service is not time you should be counting towards psychotherapy, right? And there is an innate counseling with regards to E&M services anyway, right? You're going to be counseling the member in some way, diet, change in behavior, whatever. So that in itself isn't psychotherapy either. That's just a part of the E&M service. So as an auditor, you're looking for that stuff. You're looking for those kind of like key things within the documentation saying, okay, if this right here, this doesn't necessarily coincide with psychotherapy. So it's not really going to count towards that 60 minutes or that 45 minutes that you're going to need for the codes. I will say too, the treatment plan, and I think I brought that up before. The treatment plan is also that driver of that time, because you're establishing what care that member is going to be having throughout that period of service. So, you're in the treatment plan. There should be not necessarily the exact codes or the exact time, but there should be a general kind of understanding in that treatment plan saying this is how long this person's supposed to be getting those services and what are the things that are going to be provided when I actually render these services. And so the documentation itself should support the time and not necessarily you having to always say, I spent this time to this time, or I spent this time to this time. So it all connects. And I think Renee is saying that it all connects with each other, right? Everything connects,
Right.
and it's a holistic record instead of just a single note or a single thing that you're looking at.
Well, and so you bring up a good point, which is, and this is really the difference between an auditor and a coder. A coder may just be looking at the four corners of a piece of paper for the immediacy of what's being billed, whereas an auditor is looking at 360 degrees. So when you bring up something like the treatment plan, you're looking at the treatment plan and how that treatment plan is symbiotically working with each date of service for which you are reviewing as part of that audit. Whereas a coder may just be looking at the four corners of that paper. The other thing that you brought up, which is an important piece, is this thing, the premise of the 8-minute rule. And for people that don't know the 8-minute rule, it also transcends into other types of therapy, such as physical and occupational therapy. And so the one thing that I will always caution people about is that when you are looking at an impossible day scenario for timed codes in speech language therapy, physical therapy, occupational therapy, and behavioral health, which are timed codes, is this premise of the 8-minute rule, which, as David has pointed out, in the CMS world, even though the CPT code may say 15 minutes face to face, 15 minutes face to face means 8 minutes to 22 minutes or 23 minutes, whatever that number is. And so you may have a situation where on its face, it appears to be an impossible day, but the provider has a huge amount of leeway. 8 minutes is not 15 minutes, and you can easily creep into an impossible day that didn't exist. And so, when I was an instructor at the OIG Special Agent Basic Training, I would always use PT as the example of that, because you could easily find an impossible day that is not an impossible day, and you must take that with a grain of salt. So, Renee, we're coming to the end of our time, and I want to give you the last word, because as a very seasoned investigator across a number of things, including behavioral health, what are some of the key things that you are doing when you're doing a behavioral health SIU investigation, while we stay away from checklists because we do not think that one size fits all. We think that there are some things that are always going to be standards, right? You're always going to do the following things. And whether you want to call that a checklist or just kind of your innate things that you always do as an investigator, what are some of the things that you would suggest for someone who is getting into doing these kinds of investigations? What are kind of the always do this versus you never want to put the square peg in the round hole, but there are going to be some times where the square peg and the square hole are always going to be there. What are kind of some of the Renee Sloan, I always do these things when I'm conducting these investigations?
I joke with people a lot of times that, I tend to be a little, I talk a lot. And so but I also explain a lot. And it's a running joke with friends and family. But the thing that I do both personally and professionally is I'm always asking, but why? But why? What why is that happening? Why are you doing that? What are you doing to actually, and in behavioral health, it's, you know, not necessarily always why, but what did you do? What was the intervention? The parent and I spoke about the patient's progress. What did you talk about? What did you discuss? What are the next level of interventions that you're going to be trying to do? What is, and always asking that, why or what in any investigation, I think is always important, because you're always wondering, what led to the next step? What led from the initial assessment of that patient to then what came next, the intervention, and then to what came next, the treatment plan, and what is the ultimate goal for that patient. So it's always what or why did something happen. So
and it always starts with, and really, I mean, it just gets back to what, when we're talking about the 5 Ws with David, but it'll always get back to, what does the policy say, and how do the things that you've documented fit into that policy, right? Is the square peg fitting into the square hole, or are you trying to brute force the square peg into the round hole by creating a little bit of documentation? My favorite is, and just to kind of close this out, when you're talking about the what or the why, it's oftentimes we see this in the E&M world, right? Because people tend to know that world a little bit better, is when the provider documents in their notes reviewed labs, and they just leave it at that. And there isn't an analysis of, reviewed labs, discuss with patient their high cholesterol, possible interventions. The fact of the matter is what a lot of providers don't realize is that there are instances when fully documenting those reviews can lead to potentially opportunities for additional revenue, legitimate avenues for revenue, because there are codes that involve review of test results and treatment plans and things of the sort, that by just writing reviewed labs is not going to get you that. And it's really in a similar vein in the BH space. It's that, what is that, spoke to the parent about XYZ. What did you talk about is going to get you there. So, yeah, I mean, look, I think behavioral health to me is, I think, one of the more complex areas for investigations and audits. It's a touchy subject, right? Because we didn't even get to talk about substance abuse disorder and behavior modification and the collateral things of things like drug testing. And we know that a lot in the UDT space, qualitative and quantitative. And the fact that oftentimes in the BH space, SUD or substance abuse disorder comes into that, right? That whole premise of behavior modification. And that's a whole other area. But there's a whole bunch of collateral things that come out of this. We could probably talk about these things for hours, particularly since the two of you do this every day, all day. There's just so many things that we can continue to talk about. So I want to give people some time to finish having lunch. So As always, it's great to see you guys. As always, it's great to have people come in. We appreciate everybody who was here for this. We appreciate all the time that people take from their day. Again, if you want to see any of our previous LinkedIn lives, you can always catch them on our YouTube channel. Just go to YouTube, look for Advize Health, subscribe, hit that button that says subscribe. You can get all of our previous recordings of our LinkedIn lives. You can also get our weekly OIG roundtable discussions that come every week in our newsletter. If you are not getting our newsletter, just shoot us a message at hello@advize, A-D-V-I-Z-E health.com. You can get your newsletter delivered to your inbox every Friday. It comes. Again, questions, comments, concerns. We're always looking to expand our topics, so we appreciate everybody taking the time to spend in that day. We give everybody a little bit of time to finish that lunch. David and Renee, always good to see you. Appreciate
Awesome.
your time.
Thank
And
you,
thanks
Eric.
again for tuning into this month's LinkedIn Live. We'll see you next month.
Oh, thank you.
Thank you.